Hello everyone, welcome to Unacademy. Let's crack NEET PG. I'm Dr. Shilpa Dinesh. I'm Dr. Shilpa Dinesh. I'm a practicing pediatric consultant and an educator in Unacademy. I have an experience of teaching undergraduate and postgraduate medical students. I have done my MBBS and graduate from the University of Health Sciences. So today we are going to discuss on the approach to bleeding disorders. So when a bleeding child comes with an ecchymotic patch or a recurrent episode of joint bleed, so how will you assess these children? That is the class today, and various causes of bleeding disorders we are going to discuss today. So before that, I would want to talk a little bit about Unacademy. Unacademy is India's largest online learning platform, and there are a lot of benefits you can avail from this platform. Firstly, the daily life classes. Okay, so there are various educators in this platform, and they have regular classes happening. You can attend your favorite educator's class, engage in discussion, ask your doubts, and these doubts will be immediately answered in the live chat. Next, coming to the structured course. So whenever you're preparing for your entrance exam, you have to have a structured approach. You need to plan really well. So by the time you give your exams, you would have revised very well. So here in Unacademy, all our courses are structured in line with your exam syllabus, and this is going to be a huge boost for your preparation. Next, coming to the live tests and quizzes. So whenever you're preparing for your entrance exam, you have to analyze and evaluate yourself. Okay, so you need to know what are your strong areas, what are your weak areas. So this is possible only if you attend as many tests and quizzes as possible. Okay, so here in an academy, there are regular tests and quizzes happening. This will help you to evaluate yourself. It will give you a detailed analysis of your performance. Okay, this will be again you'll be able to concentrate on the subjects where you are not that strong at. This is very important. So whenever you're preparing, attending tests and quizzes are very important. Okay, next, coming to the unlimited access. So once you subscribe to the subscription, you get unlimited access to the subscription platform. So you get access to all the classes which are exclusive to the subscription. Okay, so even if you have missed a live class, you can go back and watch the recorded classes again and again. All this in the comfort of your home, in the comfort of your own device. So I highly recommend this platform, and using this platform from the beginning part of your preparation will take you a long way. Okay, so these are the top educators in the platform, and they have again regular classes, daily classes, so you can attend their classes as well. So what are the courses offered? So basically the 19 subjects which are required for NEET PG preparation are taught in this platform, and also there are various courses like the foundation course, there are crash courses, there are batch courses. So these are all short courses of each subject. So you can go access the Unacademy app and you can check these courses yourself, and you can subscribe to them and you can attend these classes. Okay. So next, coming to the NEET PG subscription package. So as you can see, the NEET PG subscription varies from 1 month to 2 years. So I would suggest the 1 year or the 2 year subscription, especially for the students who are in their third year, in the final year, or in the internship, where they don't find time for the entire day to sit and study, right? And also, if you're starting to prepare from the third year, you won't be able to give your exams so until you finish your internship, or until you're in your internship. So for them, the 1 year, 2 year subscription becomes very reasonable, very economical. Okay, so for the students who are in their, giving their NEET PG 2021, for them the 6 month subscription suffice. The 6 month subscription will cost you 20,000, and using my code Shilpa 10, you get a 10% discount, and it will come up to 18,000. And the 1 year subscription costs you 25,000, and using my code Shilpa 10, it will come up to 22,500. Okay, and the 2 year subscription costs you 30,000, and using my code Shilpa 10, you get a 10% discount, and it will come up to 27,000. So as you can see, the costs are very reasonable, very economical, and I would highly suggest this platform. Okay, so now we'll go to today's topic. So before that, as I had discussed in my last class, we had a quiz, and there were various questions on the marrow, on the hypocellularity and the hypercellular marrows. So just so that we'll finish up, we'll make it a complete topic. So I'll be discussing basically a little points on what are the causes of hypercellular and what are the causes of hypercellular marrow. Okay, so basically in the marrow there are various erythroid cells being produced. So when the production is less than the normal is called as hypocellular. When it is more than the normal, it is called hypercellular. Okay, so hypocellular marrow. hypercellular marrow. So in the hypercellular marrow, so most of the causes of aplastic anemia, so causes of aplastic anemia are the causes for hypocellular marrow. So especially in the acquired causes, we have various viral infections like the parvovirus B19, the EBV infections, cytomegaloviral infections, right? So these infections can cause hypocellular marrow, HIV. Then I was talking about the parvovirus. So these are the various. Okay. So and drugs, what certain drugs can also cause, especially the antineoplastic drugs. Okay, antineoplastic drugs, they can cause hypocellular marrow. Okay, so also various other aplastic anemia causes like Fanconi anemia, right? So these are all various causes of hypocellular marrow. Okay, so next, to come into the myelodysplastic syndrome, you shouldn't get confused. So myelodysplastic syndrome, both hypocellular and hypercellular marrow is present. So only but the majority is hypercellular marrow. So the only the hypoplastic variant of the myelodysplastic syndrome comes under the hypocellular marrow. Okay, so whenever there is a question on the hypocellular marrow, you always consider the myelodysplastic syndrome to have a hypercellular marrow unless they specify the disease has hypoplastic marrow. Okay, so now coming to the hypercellular marrow, so there are various conditions. Okay, for example, the paroxysmal nocturnal hemoglobinuria. Okay, one is the paroxysmal nocturnal hemoglobinuria. Then there is this autoimmune disorders like the SLE. So SLE, there could be a hypercellular marrow. Okay, storage disorders like the Gaucher's syndrome, Gaucher's disease. Okay, the storage disorder like Gaucher disease. So these are another cause. Even myelodysplastic syndrome comes under hypercellular marrow. So these are the various causes you have to keep in mind. Okay, so the question in our quiz we were seeing nocturnal hemoglobinuria. So they were asking the features of paroxysmal nocturnal hemoglobinuria. In there, there will be a hypercellular marrow. Okay, so that is why this discussion is happening. So you should keep that in mind. Okay, now coming to the approach to bleeding disorders. So first thing is, you need, when a child who comes to the your ER or to the casualty with bleeding, you need to check for the vitals. Okay, you need to assess the severity of the blood loss. You need to assess the severity of blood loss. Okay, this is very important to stabilize this child. Based on this, you will be able to know, does this child require fluid bolus or blood transfusion. So this that is why a child who comes with bleeding, you have to assess for the severity and assess the vitals, or this child might go into a shock. Okay, so that is why this is very important. Next, so the causes of bleeding, the cause of bleeding could be because of a platelet decreased platelet count, or it could be because of platelet dysfunction, or it could be because of a coagulation disorder. Okay, so these are the various causes why a child could bleed. Fine. Next, so first coming to the causes of thrombocytopenia. So one very important cause is the idiopathic thrombocytopenic purpura. So we'll be having a special class on this itself. So one of the main causes is the idiopathic thrombocytopenic purpura. Next is the infection. So now I've told you, so there are various infections. The most common infection where you're scared of the platelet count low being the dengue, right? So dengue, there is a low platelet count. In hepatitis B, HIV, right? In the starch infections like the CMV, there is the rubella. So there you see low platelet count. So where else do you see? In malaria. So right, in malaria we see a low platelet count. So these are the various infections where you have to keep an eye for low platelet count. Then there are various drugs which can cause thrombocytopenia. So there are drugs like linezolid. So linezolid is one drug when you start. First of all, it is used against MRSA organisms. And when you start, you have to keep an eye, or you should monitor for platelet counts, okay, because there can these children can go for severe thrombocytopenia. So what are the other drugs like quinine? There could be quinine or digoxin. So these are the various drugs which can cause thrombocytopenia. Fine. Now coming to the thrombotic microangiopathy. So basically in the small vessels there will be thrombosis and there could be hemolysis in these conditions. So what are the conditions which can cause thrombotic microangiopathy? One is the thrombotic thrombocytopenic purpura. Thrombotic thrombocytopenic purpura. Also the HUS, that is the hemolytic uremic syndrome. Okay, so these are the various thrombotic microangiopathies. Next, malignancies. Yes, malignancies, there will be pancytopenia, leukemia, lymphoma. Okay, all the other solid tumors also will have thrombocytopenia. So that is another cause. So a child is being having thrombocytopenia and a mild decrease in the hemoglobin also, you have to keep an eye. I mean, you have to be alert that this could be a malignancy as well. Okay, what are the autoimmune conditions which can cause thrombocytopenia? So there is this SLE syndrome. SLE can cause APLA syndrome. There is antiphospholipid antibody syndrome. So these can cause thrombocytopenia. Immunodeficiency is very important. You need to know. Immunodeficiency is the Wiskott-Aldrich syndrome. Wiskott-Aldrich syndrome a very important presentation of an immunodeficiency disorder. That is in Wiskott-Aldrich syndrome, there is thrombocytopenia. So in these children, there can be severe bleed. So there is something called as a Wiskott-Aldrich syndrome spectrum. So they may have a mild eczema to severe bleed. So the presentation could be varied. Okay. So in these children, one of the cause for mortality is bleeding. Okay. So for example, a child would have gone under circumcision and the child would have had severe bleed. That is one of the presentations. Okay, Wiskott-Aldrich syndrome. This is a X-linked disorder. Fine. And also HIV is another acquired immunodeficiency. Next, bone marrow failure. So what are the conditions which can cause bone marrow failure, like Fanconi anemia, Schwarzman-Diamond syndrome? So I was talking about the inheritable causes of aplastic anemia, right? So these are also causes of bone marrow failure, like hypocellular marrow, Fanconi anemia, then Schwarzman-Diamond syndrome. Okay, so in cases of where does marrow replacement occur? In which conditions does marrow replacement occur? Yeah, marrow replacement occurs especially in the storage disorders like the Gaucher's disease, right? Like Gaucher's disease. So these are the various causes of thrombocytopenia, and that is why you should remember based on this heading. So if when you remember based on these headings, there's a very great chance you will forget. These are all very common conditions. I mean, they're very known conditions. There is nothing like very difficult. But only thing is, if you remember the headings, you will be able to remember better. Next, coming to the qualitative disorders of platelet function. So basically, the platelet dysfunction, the function of the platelet is affected. So in this, there are inherited and acquired causes. So in these inherited causes, two are very important to remember. Is called as the Glanzmann thrombasthenia. Next is the Bernard-Salyer syndrome. So you cannot forget this. Bernard-Salyer. Okay. So other than that, there is this gray platelet syndrome, gray platelet syndrome, and the dense body deficiency. So you just keep in mind, but don't go hell behind it. Okay. So the Glanzmann thrombasthenia and Bernard-Salyer syndrome is very important at the inherited cause for platelet function. Next, coming to the acquired causes. So in the acquired causes, what could cause a platelet dysfunction? So certain medications can cause, chronic renal failure can cause, cardiopulmonary bypass. So these are the various causes for platelet dysfunction. Okay, chronic renal failure, cardiopulmonary bypass. Okay, next going to the coagulation disorders. So in the coagulation disorders, that is the inherited disorders and the acquired disorders. So in the inherited disorders, you know the most common ones are The hemophilia A and B. There is von Willebrand disease. Then there is afibrinogenemia. So these are the various causes, inherited ones. Next, coming to the acquired causes. What are the acquired causes? So if there is any liver disorder, right? So any liver disease. If there is any drug overdose, for example, warfarin overdose. If there is vitamin K deficiency. Okay, vitamin K deficiency. So these are very important causes of coagulation disorders, and you have to keep in mind. So next, coming to the pathogenesis. So you should be knowing the hemostasis. So basically bleeding is controlled if the hemostasis is good. So if the hemostasis is affected, there is increased bleeding, right? So you need to know how is the hemostasis maintained, right? So in the hemostasis, the process of hemostasis has two phases. One is the cellular phase and the other is the fluid phase. So what happens? What are the cells which are involved in cellular phase? One is the platelets, and the platelets are in the cellular phase, and also the vascular wall is very important part of the hemostasis. Okay, so vascular wall. Next, coming to the fluid phase. So in the fluid phase, plasma proteins play an important role. Okay, so this physiology of hemostasis is very complex. It depends on the blood flow. Okay, it depends on the blood flow and the local response to the vascular injury. Okay, so it all depends on the blood flow and the local response, vascular response to the injury. Next, so this fluid phase has three steps. Okay, has three processes. So what are these three processes? One is there is a multiple step which involves a zymogen. So this zymogen leads to the formation of thrombin. Okay, there is a zymogen uh, that leads to thrombin generation. Next, the second is what? So now what the thrombin is formed. This thrombin leads to the formation of fibrin clot. Okay, thrombin leads to the formation of fibrin clot. Now, next what happens? There is the fibrin clot, right? So then there is a complex fibrinolytic mechanism which happens, which will limit the propagation of the clot. So the clot is formed, but now we should be careful the clot is not dislodged. So there is a very complex fibrinolytic mechanism takes place, which will prevent the propagation of clot. So fibrinolytic mechanism to prevent this propagation of clot. So this is the main hemostasis mechanism. But also the coagulation process is very important. How the factors are formed, right? So you know there is the intrinsic pathway and the extrinsic pathway, right? So the intrinsic pathway. So this is the coagulation cascade. So the intrinsic pathway and the extrinsic pathway. So do you all know which are the so the prothrombin time indicates which pathway? Tell me. So the prothrombin time is indicated by the extrinsic pathway. Okay, prothrombin time. While the APTT, that is the activated partial thromboplastin time, APTT is a measure of the intrinsic pathway. The more common out of these pathways is the extrinsic pathway. Fine. So now in the intrinsic pathway, we start with the intrinsic pathway. How does it happen? So there is a contact activation, right? So there is a contact activation. One second. Yeah. So there is a contact activation happening. That will activate the factor 12. Okay. factor 12. Now this activated factor 12 will further activate factor 11. Okay, fine. Now this factor 11 will further activate factor 9. Okay, so this you should know. Next, this activated factor 9 will activate the factor 8. Okay, along with calcium and platelet factor. Okay, now in the extrinsic factor it starts with factor 7. So factor 7 along with calcium and tissue factor. So remember, calcium and tissue factor, the factor 7 gets activated. Okay, so this factor 7 and this activated factor 7 and factor 8 will no, one second, sorry. So the factor 7, activated factor 7 will lead to the formation of factor 8, and this factor 8 with the help of the activated factor 8 will activate factor 10. Okay, so this factor 10 is needed for the conversion of factor 2 to factor 2 thrombin. So basically activated factor 2 is the thrombin. Okay, so that will lead to the prothrombin. Okay, prothrombin forms the thrombin. That is especially with the activated factor 5 and calcium and the platelet factor. Okay, so now this thrombin, so this thrombin is very important to form the fibrin clot. So I already told you, so the formation of thrombin leads to the further production of fibrin clot. So this thrombin helps in the formation of fibrin. Okay, also this thrombin is very important in the conversion of factor 13 to factor 13A, that is the activated. Okay, so that is also very important. Okay, so these two, so the thrombin is very important in conversion of factor 13 to activated factor 13, and also the conversion of fibrinogen, that is factor 1 to fibrin. Okay, and that leads to the formation of fibrin clot. So this is the mechanism you have to keep in mind. So you should know the intrinsic pathway and the extrinsic pathway. Extrinsic pathway is more common, which helps in the maintenance of the hemostasis or the coagulation. So the prothrombin is a measure of the extrinsic pathway, while the activated partial thromboplastin time is the measure of the intrinsic pathway. Okay, so this is the coagulation cascade you have to keep it. Fine. So next, coming to the clinical evaluation. So one thing is, you have to know when a child comes, you have to know the age of the child. So age of onset. So when is the bleeding happening? So age of onset. Okay, this will give you a clue. Is it a acute condition or is it being a chronic condition? So age of onset of bleeding. Type and the site of bleeding. So type. So basically now you have to know, is it a mucosal bleed or it is a cutaneous bleed or is it a deep vascular bleed? That will give you a clue. Okay, or is it an ecchymotic patch or is it just a petechiae? That will give you a clue. It will be a platelet disorder or it's a coagulation disorder. So we'll be talking in the next slide about these types. Okay, so type of bleed. The site of bleed. Site of bleed. Okay, so next, is it spontaneous? Is it spontaneous or is it because after a intervention? Right, so is it spontaneous? Just the child is simply sitting and the child has a bleed. So is it spontaneous or is it after intervention or is it after a trauma? So that is important. So this will help you to measure. So next, the duration of bleed. Duration of bleed. Also, if there is any history of infection, So I've already discussed in the rheumatological sessions in the Unacademy platform in the special class. So Henoch-Chondrin purpura has a preceding upper respiratory tract infection, right? So we've discussed about the etiology, what other bacterial infections that can cause, that has been attributed to the etiology of HSV. So like that, the history of infection has to be asked for. So it could give you a clue. It could be one of the disease or disorders. Okay, so next you have to ask for history of diarrhea, dysentery. So diarrhea, dysentery, especially in very important in HUS. So in hemolytic uremic syndrome, so a child would have had diarrhea, okay, and there will be anemia, there will be thrombocytopenia, and the renal parameters are abnormal. So there you are anemic. That is why the history of diarrhea is also to be asked for. Okay, so this is very important. Then you have to ask for history of blood transfusions, history of transfusion. Has the child been receiving blood? So this also tells you it could be a chronic disease, right? So family history is very important. So you have to take a pedigree. Okay, you have to take a pedigree and you have to document any abortions, any death in the sibling or in the family. See, a 3 generation pedigree should be taken. So especially if it's an X-linked disorder, you won't be able to see in the just in the parent generation. From the grandparents generation, you have to get a 3 generation pedigree. So that will give you a clue if it is any genetic disorder. Okay, to have a clue on a genetic disorder. Okay, now that is very important. So especially hemophilia is more common in males, but if it's a von Willebrand disorder, it is seen in girls as well. Okay, so this is very important. Next, if there is bleeding from the umbilical stump, what do you suspect? If there is bleeding from the umbilical stump, what do you suspect? If there is bleeding from umbilical stump, it could be because of the deficiency of factor 13. Okay, factor 13 deficiency can also be suspected in such conditions. Next, what else? So if there is any vascular malformations, you have to see. Splenomegaly should be checked for. The splenomegaly, especially if there is malignancy, if there is collagen disorder, if there is any vascular disorders, it will give you a clue, right? So hemangiomas. Do you all know about Kasabek-Merritt syndrome? Do you all know Kasabek-Merritt syndrome? So Kasabek-Merritt syndrome is another condition where there is bleed. Basically, over here there are huge hemangiomas, okay, along with telangiectasia. So this hemangiomas can be there anywhere. Okay, they can be in the throat, they can be in the liver and all. So Kasabek-Merritt syndrome. So based on the severity, so the mortality rate becomes very high because they bleed severely. Okay, so Kasabek-Merritt syndrome is one of the bleeding disorder where there will be thrombocytopenia and there will be huge hemangiomas. Okay, remember this. This is a question. It is a question to be remembered. Okay, next. So this was, yeah. So we have discussed. Yeah. So now we'll see how do you differentiate a platelet disorder and a coagulation disorder based on the history. So we need to know the site of the bleed, what kind of petechiae or what kind of ecchymosis is it, is there any hemarthrosis or muscle bleeding. So both of these will present in a different way. So when you see a child who comes with a bleeding disorder, you will based on the history itself, you should be able to know, is it a coagulation disorder or platelet disorder. So that is why when you get a clinical scenario, this chart becomes very important. Okay, fine. Next, the platelet disorder. So in the platelet disorder, the most common area of bleed is the skin and the mucous membrane. So remember, it is the skin and the mucous membrane. So skin and the mucous membrane. So in the mucous membrane means what? If there is any epistaxis, is there any oral bleed, or is there any gastrointestinal bleed? Okay, so that will tell you it could be because of a platelet disorder. While the coagulation disorder, tell me what are the sites for coagulation disorder? What are the common sites? So this could be bleed in the soft tissue, in the joints, in the muscles, in the deep muscles. Okay, that could be okay in the soft tissue, muscle, in the joints. Fine? Yes. Next, coming to petechiae. So tell me, petechiae is common in platelet disorder or coagulation disorder? So petechiae, remember, P for platelets. So petechiae is present in platelet disorders and not in coagulation disorder. So basically petechiae are what? Are pinpoint bleed points on the skin. They are pinpoint. So all are P. So petechiae is in platelet disorders and petechiae is a pinpoint bleeds in the skin. Next, ecchymosis. So in the ecchymosis, in the platelet disorder, how is it? How are the ecchymosis? So ecchymosis are small. So petechiae is small. So even the ecchymosis is small. Okay, it is small and superficial. Okay, while the coagulation disorder, the ecchymosis are large and deep. Okay. Next, tell me hemarthrosis and hemarthrosis and muscle bleeding. Where is it seen? So you have already seen the site of bleed. So in the soft tissue muscle joints are involved in coagulation disorders. So hemarthrosis muscle bleeding is more common in the coagulation disorders. Okay, so it is more common in the coagulation disorders, while in platelet disorder it is rarely present. Okay, very rare phenomena. So when a platelet disorder presents with a muscle bleed, you might get confused. So it's a very rare phenomena, maybe because there could be an underlying other infection, severe infection also. Okay, but it's more common in a coagulation disorder. Bleeding after a minor trauma. Bleeding after a minor trauma. Yes, bleeding after minor trauma is in platelet disorders and not a common condition in a coagulation disorder. So all small things, so that's what everything small in the platelet, right? So bleeding after surgery. So after surgery, immediately it is common. I mean, very mild immediate bleed might be there in platelet, but it is a severe bleed in a coagulation disorder or a delayed bleed. Okay, so this is a immediate bleed, immediate, and it is mild. While in a coagulation disorder, it is delayed and it can be severe. Okay. So now tell me the examples for platelet disorders. So very important platelet disorder is the idiopathic thrombocytopenic purpura. While the coagulation disorder, very important is the hemophilia. Okay. So hemophilia is the most common. So this is very important. This is very important slide. So you have to know how do you differentiate a platelet. So even in the clinical presentation, what did I say? First, you should know the age of onset of bleeding and the type of bleed. That is the very important thing. So in your history, you should be able to differentiate between a platelet disorder and coagulation disorder. So we'll do a fast revision of this slide. So in the site of bleeding in a platelet disorder is skin and mucous membrane. While for the coagulation disorder, it is soft tissue, muscle and joints. While petechiae, the pinpoint bleeds on the skin, are common in platelet disorder. So P for P, remember. While in the coagulation disorder, petechiae are not seen. Why? You see ecchymosis. So the ecchymosis in the platelet disorders are small and superficial. While in coagulation disorder, it is large and deep. So the muscles are involved, so you can think it is deep. Okay. Hemarthrosis muscle bleeding are very rare in platelet disorders, while it is very common in coagulation disorder. Bleeding after minor trauma is present. See, remember, bleeding after minor trauma is present with severe minor trauma and may not in coagulation disorder. Minor trauma is what? Okay, it is more of a spontaneous bleed. Okay, then bleeding after surgery, immediate, and it is mild in platelet disorder. While in coagulation disorders, it will take up to 1 to 2 days for a bleed to happen after surgery, and it is often severe. Okay, the best example for platelet disorder is the idiopathic thrombocytopenic purpura, and for coagulation disorder is the hemophilia. Fine. So this is the very important thing you have to keep in mind. Okay, one second. Yeah. So now coming to the lab test. So what will you get? First in the lab test, what will you do? So when you get a hemogram, first any child you get a hemogram, right? So when you get a blood CBC, what will you see? You will see the platelet count. So the platelet count will decrease because in a coagulation disorders you won't be able to know. So if it's a platelet disorder, platelet count will reduce. Okay. Next, when you get a peripheral smear, you can see the morphology of the platelets, like morphology of the of platelets and RBCs are very important. See, for example, in Viscott-Aldrich syndrome, the platelets are very small. Okay, the platelets are small, right? So certain inherited disorders will have an abnormal shape of the platelet. So that itself also can give a clue. Okay, next. So you have to screen for microangiopathic hemolysis. So you have to check for anemia. You have to check for the bilirubin levels in these patients also. Okay, screen for the microangiopathic hemolysis. So what was I talking about? HUS is a very important cause of microangiopathic hemolysis. Okay, next very important, PT and APTT. So this is very important. So this will give you a clue about the coagulation disorders. Okay, so platelet is for platelet disorders, but to tell about the coagulation disorders, PT, APTT are very important. So coagulation disorders. Okay, so bleeding time was used before. Now the bleeding time is reduced. I mean, they're not using it because first of all, to reproduce every time the amount of blood loss is very difficult, and the reliability is very difficult. Okay, so this is especially bleeding time is abnormal only if the platelet count is below 1 lakh. So now the bleeding time, using the bleeding time is being avoided. Okay, as a test. Next. So where are the conditions where the bleeding time is prolonged? Tell me, where are the conditions? So one of the vasculitic disorder is the Henoch-Schönlein purpura. So in Henoch-Schönlein purpura, the bleeding time is prolonged. Also in condition like Ehlers-Danlos syndrome. Danlos syndrome. Okay, so even here the bleeding time is prolonged. So now, since the difficulty or the problems associated with the use of bleeding time, it is replaced. Now it is replaced by the platelet aggregation studies. Okay, platelet aggregation studies. Okay, platelet aggregation studies. So this helps. Um, So this helps in evaluating inherited and acquired causes of platelet dysfunction, especially for the evaluation of von Willebrand disease also. And in von Willebrand disease, what you have to do is you have to get a von Willebrand cofactor antigen assay should be done. So these are an electrophoretic analysis also should be done. Okay, so this is very important. And if a child who is sick, okay, who is sick, a sick child comes to you with bleeding, then you have to evaluate for DIC, okay, the D dimers, fibrin levels and all that, because there could be it could be sepsis induced also. The bleeding could be sepsis induced. You have to check for DIC in these children. Okay, so next, how do you work up? So when a child with bleeding comes to you, how do you work up? So first you get a history and physical examination. So you get a history and physical examination. Okay, so you get a history and physical. So when you get a history, next what you do, you get a platelet count. So if there is thrombocytopenia, then it is at least you know the answer. I mean, there will be so many, you can think about idiopathic thrombocytopenic purpura, right? So it could be ITP, or it could be infection, it could be hypersplenism, right? It could be malignancy, it could be Fanconi anemia, right? So there could be, I've told you, there could be thrombocytopenic absent radii syndrome, or it could be any various causes of platelet dysfunction. So what are the platelet dysfunction we were talking about? Glanzmann thrombocythemia, we were talking about Werner-Solier syndrome, gray platelet syndrome, dense body syndrome. So these are the various causes of thrombocytopenia. So if there is thrombocytopenia, you can think of these. Next, there is no thrombocytopenia. The platelet count is normal. So normal platelet count. Then what should you do? So if the platelet count is normal, you have to get PT and APTT. Okay. So when you get a prothrombin time and a APTT, then you have to check. So if there is both abnormal PT and APTT, then what should you think? Both abnormal. We'll change the color. Abnormal PT and APTT. So if both are abnormal, then it could be because they are on oral coagulants, DIC, or a liver disease, or vitamin K deficiency. Vitamin K deficiency, if both are affected. See, now there is an abnormal, now I've told you already the measure of extrinsic and intrinsic pathway. So now if there is abnormal APTT, that means the intrinsic pathway is affected, APTT, and a normal PT. So what should it be? Then it is the hemophilia. Okay, hemophilia A and B, and also the von Willebrand disease. So abnormal APTT and a normal PT. If it is a abnormal PT, no, abnormal PT and a normal APTT, then what should you think? Then it could be again anticoagulant therapy. Based on what? Anticoagulant therapy. And another very important thing is the factor 7 deficiency. So factor 7 deficiency over here. So you should very remember abnormal APTT but normal PT will give you a clue for hemophilia and von Willebrand disease. But an abnormal PT and a normal APTT could be anticoagulant factor 7 deficiency. But they will ask you questions. Very important question is the liver disease. They will see both abnormal PT and APTT. Then you can chuck hemophilia and you think about liver disease. So that is very important. So history and physical examination becomes very important. Okay. So now the thrombocyto, so if when you get a history and physical examination, you get a platelet count, and if there is thrombocytopenia, you can think of various conditions where there is decreased platelet count. So one is the ITP, that is idiopathic thrombocytopenic purpura. There is infection, hypersplenism, malignancy, Fanconi anemia, thrombocytopenic absent radii syndrome, platelet dysfunction. While the platelet is normal, but the PTI-PTT is abnormal, then you have to get you have to grade based on both being abnormal or one being abnormal. So if both the PT and APTT is abnormal, it could be because the child is on oral anticoagulant or oral coagulants, okay, oral coagulants, DIC, okay, liver disease, or because of vitamin K, okay, or anticoagulants of color, anticoagulants. Okay, so if there is abnormal APTT and a normal PT, then it could be because of hemophilia A and B, or it could be von Willebrand disease. While an abnormal prothrombin time and a normal APTT will give you a clue of anticoagulants. So now we'll do a fast revision of today's topic. So yeah, so before that, I think this you will have understood. So I will start with the approach to bleeding disorder. So whenever a bleeding child comes to you, you have to check for the vitals. You have to assess the severity of the blood loss. Okay, and then you have to know if the child will require fluids or a blood transfusion is enough. Okay, so if there is a decreased platelet count, and so the causes of bleeding could be because of decreased platelet count, platelet dysfunction, or coagulation disorder. So, coming to the causes of thrombocytopenia. So, you have to remember with these headings, it will help you to remember better. The main cause of thrombocytopenia in a child is idiopathic thrombocytopenic purpura. Okay, so the infections, so very common infections which present with thrombocytopenia is dengue, malaria, hepatitis B, HIV, various torch infections. So these are the common EPV. So these are the infections you have to keep. And the very important at present we think is the dengue, right? So infections like dengue present with thrombocytopenia, and here you have to do a regular monitoring of platelets and the PCV. Okay. Next, coming to the medication. So there are various drugs which can cause thrombocytopenia, and the very important drug which causes thrombocytopenia is linezolid. Okay, so linezolid, quinine, and digoxin. So these are the few drugs which can cause thrombocytopenia. The list is very long, so you should remember very important drugs. Next, thrombotic microangiopathy, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome. So these are very important. Malignancies, especially leukemia, lymphoma, neuroblastoma, various other solid tumors will present with thrombocytopenia, right? Autoimmune diseases over here like the SLE, the APLA syndrome, right? So APLA syndrome, they can cause thrombocytopenia. Immunodeficiencies like Biscott-Aldrich syndrome, HIV, bone marrow failures like the cause of aplastic anemia like the Fanconi anemia, Schwarzman-Diamond syndrome. These are the various causes which can cause thrombocytopenia. And marrow replacement is seen in Gaucher disease. Next, coming to the qualitative disorders of platelet function. So, so now what does that mean? So basically there is platelet dysfunction, right? So inherited causes being the Glanzmann thrombosthenia, Bernard-Solier syndrome, gray platelet syndrome, and the dense body deficiency. The acquired causes being certain medications, chronic renal failure, cardiopulmonary bypass. So these are the various causes of platelet dysfunction. Next, coming to the common coagulation disorders. So the inherited disorders include the hemophilia A, hemophilia B, von Willebrand disease, A fibrogenomia, and the acquired causes being liver disease, warfarin overdose, vitamin K deficiency. These conditions you need to keep in mind. Okay, so liver disease, vitamin K deficiency is very important when you're managing when you have a clinical scenario on coagulation disorders. So you have to keep that also in mind. Whenever they say coagulation disorders, don't only think about inherited disorders, because there are various questions which will include even the liver disease or vitamin K deficiency. Fine. Next, coming to the pathogenesis. So very important. So if the hemostasis is affected, the child will bleed, right? So the hemostasis, maintenance of the hemostasis is very important to maintain the prevent the child from bleeding. So in the hemostasis, there are two phases. There is the cellular phase and the fluid phase. In the cellular phase, it is the platelets and the vascular wall which helps in the hemostasis. While in the fluid phase, it is the plasma proteins. The fluid phase is further divided into three processes. So one is a multiple step involvement of zymogen, which leads to the formation of thrombin. There is thrombin generation, and once this thrombin is formed, there is the fibrin clot formation. Next is the fibrinolytic mechanism, prevent the fibrin clot from propagation. Okay, so these are the three important processes in the fluid phase you have to keep in mind. Zymogen leads to thrombin formation. From thrombin, there is fibrin, and the fibrin clot should not be propagated. Therefore, there is the fibrinolytic mechanism. Next, so this is the coagulation cascade. So you can see there is the intrinsic pathway and the extrinsic pathway. So the intrinsic pathway is measured by the APT, while the extrinsic pathway is measured by the prothrombin time. Okay, so out of these, so the extrinsic pathway is more common. So in the intrinsic pathway, you should remember there is a contact activation that will activate the factor 12 to 12A. Then the activated factor 12 will activate factor 11, and factor 11 will activate factor 9. And this will eventually, with the help of calcium and platelet factor, activate factor 8. In the extrinsic factor, what happens? The factor 7 gets activated with the help of calcium and tissue factor, and this in turn will activate the factor 10. So both the factor 8 and factor 7 will eventually lead to the activation of factor 10. So the factor 10 with the help of activated factor 5, calcium and platelet factor will uh, convert prothrombin to thrombin, and this thrombin is very important, especially for the conversion of factor 13 to activated factor 13, and the conversion of fibrinogen to fibrin, which leads to the formation of fibrin clot. So thrombin becomes very important. Okay, so this is the important coagulation cascade you have to keep in mind. Next, so coming to the clinical evaluation. So in the clinical evaluation, what you have to keep in mind is, first, when the child comes, you have to know what was the age of onset of bleeding. So is this, so basically to know if this is a chronic or an acute condition. So age of onset of bleeding, type of bleeding, is it a bleed because of a platelet disorder? Is it because of a coagulation disorder? Site of bleed. So this site of bleed also will you give you a clue. Okay. So type of bleeding also, it could be is it a ecchymotic path, or is it a muscle bleed, or is it a petechiae, right? So that's a site of bleeding. So it is a superficial bleed, or is it a deep bleed? That is very important. Is it a spontaneous bleed, or is it after an intervention? Okay, or is it after surgery, or is it after trauma? So that is very important. Duration of bleed is again very important, right? So that will yeah. So next, coming to the history of infection. So conditions like the Henoch-Schönlein purpura, so that is one of the cause of bleeding in a child. There could be a history of infection, preceding history of infection, or a URPI. So that becomes very important. History of diarrhea and dysentery, especially if you're suspecting HUS, hemolytic uremic syndrome, then you have to ask a history of diarrhea also. Next, history of blood transfusion. So that again gives you a clue that this child could be having a chronic disease. So family history is very important. So this to evaluate a genetic disorder. So whenever you get a family history, you have to get a pedigree, and and this should be a 3-generation pedigree, and also any sibling death or any relative death or an abortion, everything should be documented properly in the pedigree. So this will give you a clue. Is it how severe is the disease as well? Next, if there is bleeding from the umbilical stump, okay, if the prolonged bleeding from the umbilical stump, then we should conclude that it could be a factor 13 deficient. So in the umbilical stump, if you'll remember, I'll ask another out of topic question, that is, if there is a delayed fall in the umbilical stump, what should you think? It's immunodeficiency disorder. So if there is a delayed fall, like beyond 2 weeks, if the delayed fall of the umbilical stump, then you should think about the leukocyte adhesion defect. So that is another question you should know. Okay, bleeding is different, fall is different. If there is a prolonged bleed, think about factor 13 deficiency. If it is a delayed fall of umbilical stump, then you have to give, it gives a clue for an immunodeficiency disorder, that is the leukocyte adhesion defect. Next, you should check for splenomegaly. So the various infections can have splenomegaly. Okay, so that itself also gives you a clue. Casaback-Merritt syndrome is another bleeding disorder which presents with severe hemangiomas. Okay, there are hemangiomas, and sometimes this hemangiomas can be so huge in the laryngeal area that can obstruct the bleeding, as obstruct the breathing in these children. So that is one syndrome you have to know, Casaback-Merritt syndrome. It has children will have thrombocytopenia. There is huge hemangiomas and telangiectasias. Okay, you should keep this in mind. So this is a chart which will differentiate between the platelet disorder and coagulation disorder. So this is very, very important. So when it comes to clinical scenario, you should be able to differentiate the two conditions. So site of bleeding. So the site, so in platelet disorders, it is the skin and mucous membrane which is affected. While in the coagulation disorders, it is the soft tissue and the muscle joints which are affected. Okay, muscle and the joint. While coming to the petechiae, so the platelet disorders have petechiae while there's no petechiae in the coagulation disorder. While the ecchymosis in the platelet disorder are small and superficial, while in the coagulation disorder it is large and it is deep. So very simple, you can remember. Just have a very pictorial memory of this, you can remember everything well. Again, hemarthrosis, muscle bleeding, is a very important feature of coagulation disorder and not a platelet disorder. So hemarthrosis, muscle bleed. So basically, the site of bleeding, you will be able to correlate to that. Now, these two very important things, bleeding after minor surgery and bleeding after minor trauma and bleeding after surgery, is very important. So minor trauma bleed is very common in platelet but not in coagulation disorder. But bleeding after surgery, for platelet disorder, it is mild and an immediate bleed, while for coagulation disorder, it's a delayed. It will take 1 to 2 days for bleeding, and it is often severe bleed. So that you should remember. Okay, the best examples for platelet disorder is the idiopathic thrombocytopenic purpura, and for the coagulation disorder, it is the hemophilia. So this you have to keep in mind. So next, coming to the laboratory test. So in the laboratory test, what you have to know is the it is the CBC. Okay, so when you get a CBC, you can first thing, whenever a child comes with you, you have to get a CBC, check if the platelets are fine. So if the platelets are decreased or not. Next, get a peripheral smear, you can see the morphology of the platelets and RBC. Okay, also you have to screen for microangiopathic hemolysis in these children. That is because, especially the HUS, hemolytic uremic syndrome. PTA-PTT is done to rule out any coagulation disorder. Okay, bleeding time was being done, but now it is being avoided because the procedure itself is very difficult. You have to every time bleed the patient, and also it is not very reliable unless the platelet count is below 1 lakh. Okay, so you should remember one few things, though it is not being done, but you should know the causes where it is prolonged. So it is prolonged in the HSP, in Ehlers-Danlos syndrome. These are few of the causes where the bleeding time is prolonged. So now, since the difficulty of doing a bleeding time, the test for bleeding time is replaced by the platelet aggregation study. So okay, so platelet aggregation, so especially for conditions which have acquired or hereditary causes of platelet dysfunction. So very important thing is, when a sick child comes with bleeding, you have to rule out the IC in these children. Okay, so this is the thing you should know. So next, coming to the workup. So when a child comes with bleeding to you, first thing is always any disease, and physical examination is very important. So once that is done, get a platelet count. If that is normal, if that is decreased, so there is thrombocytopenia, then you should think about various causes like ITP, infection, hypersplenism, malignancy, Fanconi anemia. Okay, so these are the various causes you have to keep in mind. While a normal platelet count, then you have to get a PT-APTT. This is very important. Okay, so this part you have to remember. Okay, so this will be for your clinical session. So you should remember where there is abnormal PT-APTT, where there is abnormal APTT and a normal PT, where there is an abnormal PT and a normal APTT. This is very important for your NEET PG point of view if you get a clinical scenario in a bleeding disorder. So if the both PT and APTT are abnormal, and if the child has an oral anticoagulant, PIC, liver disease or vitamin K deficiency, an abnormal APTT and a normal PT seen in normal prothrombin time is seen in hemophilia A and B or in a Wall-Willebrand disease, while an abnormal prothrombin time and a normal APTT is seen in factor 7 definition. So remember this is very, very important. Okay, so we have discussed today, we have discussed about the approach to bleeding in a child. Okay, so this was a thing. So yeah, so this is for today. So this is tomorrow. Again, tomorrow also will be a recorded class. I have some work emergency and I have to be replacing a colleague. So I will not be able to come at 1 o'clock for the regular live class. So tomorrow will be a recorded class on hemophilia. Okay. Then after that, it will be ITP. And so with hemophilia, I'll be talking about von Willebrand disease. There will be ITP, then there will be thrombotic disorders, and there will be a quiz. Oh no, not quiz. There will be splenomegaly and lymphadenopathy, and then there will be a quiz. Okay, this is the discussion which we'll be doing. And in the Unacademy platform, today at 4 p.m. I have a special class. That is today is what? Today is 19, right? To 19/7/2020 at 4 o'clock. I have a special class that is on sarcoidosis and amyloidosis, and I'll be discussing on Sjogren syndrome, and I'll be discussing on Behçet's also. So with this, all the topics of rheumatological disorders will be done. So in the month of July, we have done most all the bleeding disorders. So we'll be completing even hemophilia. So in the Unacademy platform, I'm completing rheumatological disorders. So once this is done, if I still have time, I'll be having a quiz on endocrine. So either the YouTube channel or in the special class, we'll see based where I have to be doing. I will let you all know previously itself. So we'll have a short quiz on endocrine disorders. Okay. So after that, if I still have time, one quick revision on developmental milestones we'll be doing. So this is the plan. Yeah. So this is the plan. So let's see how it will go on. Fine. Okay. So another very important thing. So the 4 things what I always say. First thing is study daily. Do not have a break. So being disciplined in your studies is very important. Okay. So study daily. Even if you're planning to have a break, at least study for 1 hour that day, so that you do not have a complete break and go into that lazy mode. Okay? At least because reading every day is very important to crack in your for your NEET PG. Second, avoid social media. So the time gets wasted very fast. You won't even know how 2-3 hours pass being on social media. So completely avoid social media. You know, deactivate your Instagram, Facebook, Snapchat, all that. Okay, so that you are only concentrating on your studies. Thirdly, if you have a study partner, discuss with them daily, at least for half an hour. It will help you to remember better. So both of you will discuss. It should be a two-way thing, not just you bluttering out. So two-way thing. So both of you will discuss. So when you tell something, the other person might have some doubt. So explain. So it's always good to discuss and explain things. It will help you to remember better. Fourthly, sleep early and wake up early. Again, that is another very important thing to have a very good memory. Okay, so this you should remember. And whenever you're subscribing to the subscription, use my code Shilpa10 to get a 10% off on the subscription. Okay, so good luck, stay well, stay safe, and stay healthy. Okay, fine. Tomorrow, and again, it's going to be a recorded class on hemophilia and von Willebrand disease. Right? See you.